Okay, today we're going to be talking about pediatric feeding disorders. This is just a mock presentation of the actual presentation I gave to the Utah School District where I completed my clinical fellowship. I didn't include it in the slides here, but before we start, I'd like to just express my gratitude to Arlene Erickson, Greg Young, Julie LeBaron, Ben Hazlitt, and all of my coworkers at Alpine School District for mentoring me as a new clinician. Okay. So if I were to wager a guess, the majority of the speech therapists that I presented this to weren't comfortable working with pediatric feeding disorders. Okay, so I started with this analogy in the presentation. So this picture is me and my wife. We went on a honeymoon to Puerto Rico. One of my favorite parts of the trip was the food. I really liked the food. These are called pinchos. Okay, anyone with a Mexican Spanish background, stop giggling. These are called pinchos. I remember what they smelled like. I remember the food very well. They smelled like garlic and smoke. It smelled so delicious. They were served on these paper plates. When we ate them, it was raining. We ate them outside, so I smelled and heard the rain mixed with the garlic and the smoke. The rain was cold, but the pinchos were warm. We just finished a hike through the jungle, and so it was a welcome addition to our stomachs, right? The bread was perfect for sopping up the sticky marinade, and I ate it next to my best friend. So, with that said, think about your favorite meal. What did it taste like or feel like in your mouth? What did it smell like or sound like? Right? When was the last time you ate it? Where did you eat it? Who was around you and how long did it take for you to finish eating? Did you leave anything behind or did you eat, lick the plate clean? Okay. Now think about your worst meal. Think about how stressful that was. Did anyone force you to eat it? Did you lose weight because you couldn't stomach it? Did it make you gag or choke? Why did you dislike this meal? So think about these experiences because some of these experiences are our kids' experience, but some of these, especially the worst meal, this is the experience of kids with pediatric feeding disorders. We'll come back to that idea, but for now, we're going to define pediatric feeding disorders. So, pediatric feeding disorders, or PFDs, are conditions that affect four aspects of a child's life, right? So, there's the medical, there's the feeding skill, nutritional, and psychosocial. It is important to remember that anorexia and ARFID are considered separate conditions under the DSM-5 criteria, and so they don't fall under the PFD umbrella. Okay, these are the four domains, and not anorexia or ARFID. So, how prevalent are PFDs? Right, so they're more prevalent than you might guess. About 1 in 37 children under the age of 5, according to a study, have pediatric feeding disorders. 1 in 37. So, what does it look like? Right, to parents, guardians, or teachers, PFD might look like this. A kid might explicitly choke on their food, or they might be losing weight, or they're underdeveloped for their age. Or a child might have sensory dysfunction, which could cause a feeding disorder or is part of a feeding disorder. Or the student might avoid their peers or teachers. So why should we implement a solution to pediatric feeding disorders on a district level? Currently, this is the why, right? Because under IDEA, we document things labeled under other health impairment, Under Section 504, right, we can provide the rationale that there is a substantial limitation of activities of daily living, and there are other laws and policies in place that provide us rationale for managing PFDs in the school setting. Really, the main thing is an ethical rationale, right? With great power must also come great responsibility. Okay, although ASHA has mandated dysphagia training in graduate programs since 2004, there is still poor self-efficacy and poor confidence in working with dysphagia or feeding disorders in school settings. Education is our children's greatest need, but first we must be fed. So, if we're going to come up with solutions for this, what might be some solutions? Well, how about a team, right? Who would belong on the team? Of course, we would have the child and the child's parents and guardians, the stakeholders. We should involve, of course, the school clinicians, right? SLP, OT, PT, school nurse, school psych. Okay. We might expect doctors, teachers, or admin to be the ones referring, but this kind of work might also involve other specialists like dentists, dietitians, food service workers. So I've put a star next to those clinicians, the SLPs, OTs, and school nurse, because we'll talk about them shortly um, in the next presentation. Okay. So what would a team um, be expected to do in a school district? Okay, what we're proposing here is that there should be a team of specialists in a school district, and there's many models of that. That's going to be covered in the next presentation. But what this team would do is to screen or evaluate PFDs, treat the PFDs, or refer, okay, as needed. So this is what that timeline might look like. So the team would get a referral and they might screen. Okay. So parents and teachers might refer, and then um, this does assume that they know to refer to the PFD team. In my experience, my very brief experience, the teachers and parents didn't know that speech therapists or even OTs handled pediatric feeding disorder cases. This is a fairly new part of the field, but it is within our scope of practice. Um, but it's lesser known that it's part of our scope of practice. Next up, if the screening indicates it, right, then the team would need to provide an evaluation in collaboration with the child's pediatrician. And then the team would need to create a treatment plan. If this is indicated, there would be a treatment plan that adheres to IDEA and or Section 504, and it would involve potential co-treatments between specialists. For example, OT, school nurse, SLP. And during the treatment portion, the team would need to adjust the goals as necessary and meet regularly. Think an IEP meeting. Okay. And then finally, the child should be able to generalize the skills without special support from this team. That's the whole goal. Um, and they should be able to generalize the skills at school and hopefully also outside of the school. So when screening and evaluating, it's going to be important to consider any congenital abnormalities chronic conditions, neurodevelopmental delays, right? The swallowing structure and behavior change throughout the development. When evaluating and treating PFDs, it will be important to discuss to consider all aspects of the child's life, not just the swallowing. It needs to be comprehensive. Okay. There are a lot of things that we can observe from the comprehensive evaluation. So, safety of the swallow, cranial nerve oral mech exam, sensory, right? The medical history. So, we need to get a case history. Um, and then let's look at the present levels, access to nutrition. Are these kids in WIC programs, for example, right? Any adaptive or medical equipment that they might need. How efficient are they at eating their lunch in the lunchroom, right? What's their response to food? Interventions, when carrying out the treatment plans, it's going to be necessary to consider the child's feeding and swallowing experience inside and out of school settings. So think the four T's: texture, temperature, taste, and time. Okay. OTs and PTs will be a great resource for posture and positioning and sensory motor considerations. Okay. The team will need to consider pacing, cue-based feeding, sensory stimulation, and biofeedback. We need to take caution with laryngomalacia if we recommend chin tucks, right? Cervical flexion. We can see that there's a host of things that this PFD team, the specialist team, will need to specialize in, but the rest of the district won't necessarily need to specialize in it, right? So hold on to this because now we're going to think about if you've ever worked with PFDs. What did you do to evaluate? What did you find? And how will you treat? Um, how did you treat the case? Here's some links to some example cases. If you have the time, and if the links still work, I'm not sure anymore. This is an old presentation, but if you do have time, give it a shot. Read through the case histories and come up with a treatment plan, including goals. I've included some 12 example goals there on that link at the bottom. And then once you've done that, you could pause the video, right? But once you've done that, what goals did you come up with? Okay. In the school setting, a physician's order or a prescription isn't required to perform clinical evaluations, to modify diets, or to provide an intervention. But there are times when a prescription or a referral or medical clearance from the pediatrician, the primary care physician, right, or other healthcare provider is indicated. For example, when the student receives part or all, if the student has a feeding tube, or they have a complex medical condition or a significant change in status, they've been hospitalized with aspiration pneumonia, they've had a recent choking incident, or they needed emergency care, they have some suspected structural abnormalities after an assessment from a medical professional, any allergies, right? So think about these goals, the safety of the swallow, the length of time, how efficient or how did they fatigue while they were eating a meal, right? We want to maximize their capabilities. What are they capable of? And then let's focus on that and enhancing that. We want the quality of life to be enhanced or preserved as well. Um, and we want to address any behavioral or sensory motor issues that could interfere with the feeding and the swallowing. Okay, so here's some of the resources. I've added links to some of the slides, and I'll go ahead and go through these slides. You can pause as needed. I've kept these slides hidden during the actual presentation, but in case you wanted the the links and the organizations, here they are. And here's the references that I used. And I ended with saying, we can do this. Because how many of you feel confident treating PFDs at your school? Right? SLPs have the potential to improve our students' outcomes in both education and healthcare. Thank you.